So I'm now going to ask our next speaker to take the podium, and we have Lynsay Stewart, who's one of our excellent Paediatric Major Trauma Centre coordinators. And Lynsay, you're going to speak about abusive head trauma and looking at responding and preventing these things from happening. So thank you.
Hi everybody, as Liam said, I'm Lynsay. I'm one of the 3 major paediatric major trauma coordinators at the Children's Hospital. It is a huge privilege to be here and actually have a session dedicated to paediatrics. You know, we are small, but we are mighty. And I think hopefully that will come across in Marie's talk, my talk, and hopefully Susanna's talk later. So I'm here to talk about, it is a fairly depressing subject. You know, Marie alluded to it a wee bit earlier. You know, she said Michael stole some of her slides, she stole some of mine, so it is good to know that we are all talking about the same thing. Michael did also touch on it earlier in his session, so I'll try and keep it as light-hearted and as easy as possible. So, as Marie alluded to, the Trauma Network went live during COVID. That was a fairly depressing time for all of us. I'm sure we all remember that. However, in the Children's Hospital, as we always do, we were able to get balloons. So this is us going live and as part of the Major Trauma Centre when we first went live. This is a slide Marie's already alluded to as well. So Marie told us that the Trauma Network is split up into the west, the south, the north, east and the east. The cohort that we work in is the west of Scotland. So although I come from the Children's Hospital in Glasgow and that forms part of GGNC, we do have local trauma units in NHS Lanarkshire, NHS Ayrshire and Arran, Dumfries and Galloway. We also have local emergency hospitals in GGNC, and again, Lanarkshire, Ayrshire and Arran, and Dumfries and Galloway. So we do see a fairly massive patient cohort at the Children's Hospital. Again, Marie did say in her report there, you know, the west of Scotland will see more than 50% of paediatric trauma, so we do see a fair amount of trauma. What is major trauma? You know, people say, why do you as trauma coordinators pick up major trauma? So this definition, I think, if you just remember this, later on in the slide, hopefully when I go through the case studies, you'll realise why we do pick them up. So major trauma is characterised by injuries that are severe enough to potentially cause death or significant long-term disability, and these injuries can come in various forms. Trauma is a serious public health problem. You know, we've heard that all day, I think, actually, just about how do we target public health, talking about prevention and things like that. How can we make things better? I do think it probably has got better over the years, you know, through to prevention and things like that. Consistently, accidental head trauma are one of the top 3 causes of death in children over the age of 1. Now, that's a fairly statistic that we should all listen to. In Scotland, 4,000 people are characterised as being defined as major trauma. 800 to 1,000 of these cases will go into the STAG audit that Marie was talking about. This is as a whole in adults. In the RHC in Glasgow, where we work, 350 to 400 patients annually are defined as trauma patients. So that's what we will see as a team. 70 to 100 of those patients are classed as major trauma, with the majority of these being head trauma. Now, our non-accidental injuries, babies and our abusive head trauma babies, like Marie said, they totally tip the graph at one end. So that is why we take them under our service. What is paediatric abusive head trauma? I'm sure everybody knows it's an overarching term for the type of physical abuse, injury inflicted to the head. Diagnosis can include bony injury, intracranial bleeding, and injury to the brain itself. There are patterns of injury that suggest abuse, again, which I'll allude on a wee bit further down the line. And it's important that healthcare providers are aware of typical injuries associated with accident versus those associated with abuse. We do also should be aware that, you know, although we do have abusive head trauma, we do still have traumatic head injuries. We have lots of children under our service who are known to social work teams. There are lots of different things. You know, these kids can have accidents. So I think it's really important that as healthcare providers, we're able to distinguish what is abusive head trauma and what is accidental head trauma. I recently did a postgrad certificate in child protection. I am totally passionate about this group of patients. Michael said this morning, this is 5% of our patient group, so it's not massive. But actually, they are a really, really tricky group to deal with. it's not just the patient we're dealing with, it's the families, the primary caregivers, the whole family as a whole. So these are just some statistics. So what are the causes of abusive head trauma? You've got blunt impact, violent shaking. I'm sure lots of people used to, that was referred to as shaking baby. We don't refer it to that anymore. It's known as violent shaking. Dropping and throwing. The majority are aged between 3 and 9 months, and I think, again, from Marie's stag data, that was clearly evident. You've seen how it was top-heavy, although it can occur in children up to 5. Again, the difficulties, 3 to 9 months, these children are not vocal, so they can't tell us exactly what happened to us. So that's what does make it difficult. Perpetrators, 65 to 90% of them are male, unfortunately. Perpetrators are usually caregivers, not always primary caregivers, so not necessarily always a mum, a dad, you've got aunties, uncles, grandparents, things like that. And there are other associated injuries with abusive head trauma. So we've got retinal hemorrhage, broken ribs, and fractured long bones. And again, I'll explain a bit about that as we go along. What are the risk factors? Again, this is just a sort of overarching thing. There's lots of risk factors. When we looked at this statistically, there's low education level, poverty. Again, as Marie alluded to in the stag report, deprivation is a massive thing in the west of Scotland. Poor mental health, domestic violence history, previous ACEs, lack of childhood experiences, lack of prenatal support. Again, what we did find is you get a lot of concealed pregnancies these days, so any of that sort of preventative stuff that could have been done in the sort of 40 weeks of pregnancy just isn't done. Family function, there's lots of different family functions these days that we're aware of. Substance misuse, and lastly, frustration and tolerance. And I know Susanna's going to talk about that later, so I won't dwell too much on that. But, I don't believe that every parent who is, accused of abusive head trauma believes to hurt their baby. Sometimes it can be, I'm sure there's loads of people out here who've needed 5 minutes, their baby's been crying for 20 minutes, and it's that whole 5 seconds of frustration that can sometimes cause it. Signs and symptoms. Again, Marie talked about, children are portable. Not many of our patients will come in through SAS or through the ambulance service. A lot of these patients will be brought in by their parents and brought straight to ED. I don't think I've ever had a parent say to me that they've ever harmed their baby, that they've ever done anything like that. They will generally come in and say they're poor feeding, they've had a seizure, they've got a decreased conscious level. So these are the types of things the signs and symptoms that these parents will present to ED. They will generally never, ever tell you what the real story is. Again, vomiting, poor feeding, respiratory failure, seizures, there's loads. The list is endless. Medical investigation, again, Marie mentioned earlier, is a lengthy process. If a child does come in with some of those signs and symptoms, generally the first line of investigation will be CT. And if the CT is positive and shows any sort of bleeding or anything like that, there will generally always be some sort of CP investigation started. So child protection medical examination, that's carried out by our child protection doctors. They will get involved. A notification of concern will generally have been submitted post-CT to make them aware that a child has come into the hospital, they have sustained a significant injury. However, we have no cause for why that baby has blood in their head. We have MRI. MRI tends to investigation later on down the line, but again, that's helpful for our neuro-rehab teams if these babies need any sort of neuro-rehabilitation. We've got ophthalmology. Michael, again, touched a bit on that this morning. Retinal hemorrhaging, that's what we're looking for with that. Skeletal survey. Royal College of Radiologists, they are a massive, massive part of this. There's loads of imaging. These babies get loads of imaging. So they'll get an initial skeletal survey when they come in, and that will also be repeated at 2 weeks. So the reason for repeat at 2 weeks is these acute rib fractures or anything like that aren't always evident until 2 weeks down the line. You start to see a bit of callus formation and things like that, and hence the reason. So I think the initial skeletal survey, I think, is 32 x-rays, so it's loads. So you have to be fairly confident that the mechanism doesn't fit with the injury and that we are going down a child protection investigation because these babies are being exposed to, radiation. Metabolic investigations, these are always carried out generally as well, so our metabolic consultants also generally get involved. There's lots of different causes for blood in your head. It's not just abusive head trauma or accidental head trauma. There's lots of metabolic reasons for it. They have lots of, you have a complete blood count with platelets. Again, that all ties into your medical management and your urinary analysis. So there's lots. And you can see even just from that slide alone that there's multiple teams involved with these babies. We then have an initial referral discussion. So that is generally when the patients come in, we've decided that we have a baby, we have an injury that doesn't match with the mechanism of injury. We then tend to take it to initial referral discussion. This involves police, social work and health. Now this is purely a fact-finding thing. This is not to determine the outcome for the patient, what we're going to do. It is purely fact-finding. As health, we provide information as to what the patients come with, what sort of investigations they're having. Police will look into any sort of background history and things like that for the patients. And again, social work will do their bit and they will bring that all together. So there's lots and lots of things. How do medical teams determine how do we know, how can we say, if somebody doesn't tell us what they've harmed their child, how do we determine that it is abusive head trauma? That is down to our child protection consultants. So we have neurosurgeons, we have neurologists, we have everybody. So all together, they provide all these different bits of information, and our child protection doctors will then provide a report, which then goes to court. I know this probably doesn't really project very well, but there's loads of different things for that, but that is how they will determine probability. So they'll look at, does the baby have retinal hemorrhage? That's almost like a point. Do they have subdurals? How did they present? Did they present with apnea? Did they present with seizures? All these things will be taken into account before that final report is done. The report is never completed. It can take months for the child protection report to be completed. Again, because they come back at 2 weeks for a repeat exclusive survey, so nothing will ever be done until all of that is done. Again, that's just a quick slide on the Royal College of Radiologist guidelines. Like I said, CT is always generally the first presentation for any acute presentation of non-accidental injury. If it's normal, we don't need to proceed. If it's abnormal, there's all these different routes that we go down. Like I said earlier, I think it's important that we understand the signs and symptoms of abusive head trauma, but it is also important to realise that there can be different things that cause blood in the head. It isn't always accidental trauma. So that's the reason we do all these multiple investigations, we do all the metabolic stuff, is to rule out these things. If you're 9 times out of 10, the child protection doctor will often end up in court, and the judge might say to them, how do you know it's not a connective tissue disorder or a metabolic disorder? If we haven't done these tests, then that can quite easily get thrown out. So that is a reason that all these massive tests are done. It's a totally robust system so that they can be fairly confident that that's what it is. The top line there again, accidental head trauma, we have lots of children who are under child protection, on the child protection register, have social work care. It is, again, like I said, it is important. These children can still have accidents. And I think it's important not to just jump to that initial conclusion that that is abusive head trauma. Complications, so that first slide that I mentioned about what is major trauma, I spoke about life-changing injuries and all that sort of type of thing. Here is what the complications of abusive head trauma can be. We've seen these. In that whole 5% in that population, Marie gave lots of data on that as well. These are lots of the complications that we do see. Again, not always evident initially in the acute phase. However, as these children develop, they might not meet their milestones, they end up with learning difficulties. We have had kids develop sort of left-sided hemis, things like that. So again, that's talking about rehab. I'm a great advocate for rehab. It's all about our trauma network logo is saving lives, giving lives back. So how can we give these kids their lives back? And it's important if they have all these things that they get the appropriate rehab at the appropriate time in their life. Notification concern, I batter on about this all the time. This is my major gripe out of everything in the whole wide world. Notification of concern is a way that health will notify if you have a concern about a patient, about a family. We're pretty good at sharing information with ourselves in health, I think. However, how does social work know that that baby's been brought in if the patient brought them to A&E? How do the police then know? So this is a means of us communicating to social work, police, and all these things to say that a patient has been brought in, they have sustained an injury where the mechanism doesn't fit. It's a document that highlights a concern. It's a shared between health, child protection, and social work agencies and police. Obviously, this is a health thing, but it's stored on clinical portal. I know there's lots of different other people out there. You will have your own way of reporting, how you report a concern. It requires discussion with the family and social work in order to complete it. So anytime anybody fills a notification of concern in, you must discuss it with the family. Now, I've done lots, and I'd probably say 9 times out of 10 I've not really had anybody who's been objected to it at all. It doesn't always automatically trigger a child protection investigation, and I think that's the main bit to realise. Lots of people are reluctant to fill it in because they think somebody else will do it, it's somebody else's responsibility. But it doesn't always. And again, I think the fear of standing up in court, I think if they fill it in, they're going to end up standing up in court. But that's absolutely not the reason. But it is important that these are completed. And again, if you take anything away, this is the thing I would say, it's everybody's responsibility to report concerns. Failure to report concerns may return in further harm to the child, which is what we don't want. Major trauma coordinators. So this is where our role fits in. As you can see from that, there is multiple teams involved in these babies. Like I say, they complete 5% of our neurosurgical admissions, so they're a fairly small number. However, they are tricky. So the role of the major trauma coordinator, there's trauma coordinators across the whole network now, in adults and in peds. So again, we all kind of probably do varying roles. The adults have got a much bigger population for major trauma than what we do. Thankfully, our population is much smaller. Our main role is we're responsible for coordination of day-to-day management of major trauma patients from admission to discharge and beyond. So as you can see from the picture, there's 3 of us. I was a radiographer in my past life, so I have a wealth of experience, 26 years of experience in imaging. Mark, my colleague in the middle, he's a nurse, so again, these patients have lots of nursing things to do. And Jenna, my colleague at the end, she is a physio, so again, we talk about rehabilitation and bringing that all together. So as a team, I think we've got a fun fact, 64 years of experience, I think, of working in the Children's Hospital, so we know everybody, and we can provide help all the way through the patient's journey. We're also the single point of contact for these families. We will divide and conquer with these families. We will have our own caseload for them, again, because they are really difficult to manage. So we will split them up. And again, they might see our 5 neurosurgical consultants in their 3-month stay, or our however many neurology consultants, or multiple child protection consultants. So they see lots of people. And the only person that generally doesn't change is us. We should generally know everything about what's going on with the clinical teams and things like that. We try to provide a family-centred care approach. These are tricky patients, and I think what we've seen over the years from families, if you're a parent and you generally know in your heart of hearts that you've not done anything to this baby or this child, and you then have somebody saying to you that this injury has been caused, somebody's inflicted this, it is so difficult. And we see families really knitted together at the start, and then come 2 weeks down the line or 3 weeks down the line, their family life has completely fallen apart. So again, it's really important to advocate for these patients and just have a whole family-centred approach. We liaise with local health boards. So like I say, we've got Lanarkshire, Ayrshire and Arran. If a patient was a Lanarkshire patient or an Ayrshire and Arran, it's their local team who carry out the child protection investigation. We will facilitate the imaging, all that sort of type of stuff, but the actual social work side of it will be done by their local team. So again, it is important to have somebody within the hospital, especially if they're out with locality, that can try and convey all that sort of information. I thought the easiest way to explain the role and the complexity, I think, of these children is to just run through 2 case studies that we've had recently. So this is a 5-month-old twin, previously fitting well. The story that the dad gave when he came to ED, again, picked and scooped the baby. Father stumbled while carrying him and baby became unresponsive. The dad did say he didn't fall, he didn't drop the baby, but he did stumble. Mum was downstairs changing the sibling, so Mum was unaware of what actually happened. Pre-hospitally, GCS level, GCS 4, we spoke about that GCS this morning, seizure activity, grunting and agitated. Arrived in resus, intubated for airway protection and due to being generally unstable. So this all happened at their local hospital where they presented. CT scan was performed at the local hospital. Like I said earlier, CT scan will generally always be the first line of investigation, and it provides a multiple of answers. This showed a left-sided extradural hemorrhage. So what you're thinking is that ED admitting consultant, we've got a left-sided extradural hemorrhage, we've got a dad who said that he stumbled, he didn't drop the baby, he didn't fall. What's happening? A notification of concern was completed. This was completed by their local team. Like I said, if it's out with locality, it's done locally, and the local CP teams were made aware. The patient was then a secondary transfer, like Marie spoke about, so they were taken to their primary centre, stabilised, then a secondary transfer to us for urgent neurosurgical input. Social history, we spoke about family function earlier. He lived with his mum and dad and his twin brother. Dad was in full-time employment. Mum worked part-time as a chef, although still in maternity leave, And there was no previous concerns about development. They engaged really well with prenatal care, so there was actually no concerns from this family and were not known to social work at all, or police. His diagnosis, so you can see from that scan, so he had a significant traumatic brain injury. He had a left-sided subdural hemorrhage, post-traumatic seizures, but no skull fracture was identified. So if you think back to what the causes of abusive head trauma, we don't have a skull fracture here. He did go to theatre, so he did decompression craniotomy, extradural of his subdural, and insertion of his subdural peritoneal shunt. So you can see from these 3 scans, so that was his initial scan done locally, that was his post-op scan after theatre, and then that was his pre-discharge scan. I think he was with us probably for about 5 or 6 months. So you can see from his previous discharge scan, you know, he has taken a fairly significant hit to that left side of his brain. You know, was he going to have long-term disabilities? Again, like I always say, our neurology colleagues will never prognosticate. It's really difficult. Michael said this morning, kids' brains are plastic and they recover really well. And sometimes what you see in a scan isn't always what you see in a patient. But we could sort of say that this, you know, he was going to have some sort of difficulties going forward. And again, not at that acute setting, but going forward later on in life. Talked about medical investigations. All the investigations that are done for these kids, skeletal survey, both initial and follow-up were normal. Ophthalmology, he did have bilateral, multiple layered retinal hemorrhaging. So this is his retinal hemorrhaging images. He then went on to have an MRI scan, which showed multiple subdural hemorrhaging. Nothing really new that we didn't know from his CT scan. We did see from his MR, obviously CT is a great first line of investigation. It'll let you know if you have to do anything urgently. MR does provide much better detail looking at brain tissue differentiation and things like that. So we could see from his brain MRI that he had areas of likely brain parenchymal injury. His blood cultures and virology were all completely normal. So again, looking for all these other causes, looking to rule out all these metabolic reasons, they all come back as normal. So I say he was with us probably for about 6 months, I think, in total. His discharge summary, it was really sad, and I'm sure I don't know if there's any education people, but you know, we talk about GIRFEC. I'm sure people with children will know about Shinari wheels and about all the sort of different things in that. So, you know, I think as trauma coordinators, trying to provide that holistic approach, these are things that we have to look at as well. So his pre-discharge case conference was held and he was discharged into foster care. So again, going back to that whole, as a parent, if you've generally done nothing, you're now having your baby taken off you, it is heartbreaking and it's so, so difficult. Ongoing input from hospital teams, GP and health visitor teams in relation to health. So again, that's meeting one of our Shinari wheels. His name was placed on the Child Protection Register, and the main indicator for that was child abuse. There was a referral made to the Scottish Children's Reporter. Child Protection case conference was held within a month. Now, this is always generally held within 4 weeks, and what that will be done is to make sure that the family, like our mum and dad, complying with what the restrictions and things are. CP investigation was opened up, and again, it was done by a local team. So once the patient was discharged, the local team dealt with all that type of stuff. And the social work were there to continue to support the foster carer. Social work talk about interventions. It's really difficult again. You know, what are interventions? A child protection order was placed and the child was placed in foster care. So that was done initially. So he didn't actually get home from hospital to his initial parents. He went straight into foster care. So in summary, the combination of subdural hemorrhage in multiple areas, bilateral retinal hemorrhage, seizures and apnea, which is what he generally presented with, make inflicted abusive head trauma highly likely with a predicted probability of 95%. So once the CP doctors had all the information of all the tests, they sat down, looked at that chart, and it came up with 95%. And I think just, again, his injuries were potentially life-threatening and potentially would cause long-term disability. Again, looking at that CT scan, we could probably predict that. However, again, it's very early days to prognosticate. And again, just of note, this wee boy is now back in his mum's care, and dad has left the family home and is currently serving a jail sentence. So that's pretty severe. This is just another quick case study, and again, to show you that although we have lots of child protection cases, you know, accidental injuries do happen. This is a 2-year-old boy. He was brought to ED, and the story mum gave us then was that he'd fallen from a trampoline onto concrete, which seemed reasonable. He was pre-hospitally, he had left-sided pain, fixed lateral gaze, fixed and dilated non-reactive pupils, simple airway manoeuvres, C-spine precautions were taken. He did have several vomits at home, but there was no other notable injuries to his body, so we didn't, you know, there didn't look as if there was any sort of long bone fractures or anything like that. Again, he arrived in resus, scooped up and brought by his family. He arrived in resus, he was intubated for airway protection, and again, due to being generally unstable, so similar to that first baby, when he came in, he was stabilised and taken to CT. Notification of concern was completed and discussed with our child protection consultant following his CT findings. Again, CT was that first line of investigation which gave us the answers. His social history was completely different. He lived with mum and his 2 stepbrothers. Dad was in prison for selling and possession of drugs. There was a long-standing history of neglect with this family. Previous non-engagement with social work services, so again, we went to the IRD, it's very much fact-finding. Parents, we ask parents all the time, it's part of our admission document, do you have a social worker? Definitely not, definitely not. And again, when you go to the IRDs and things like that, that's when you find out all that sort of information. This child was previously on the Child Protection Register for neglect and was actually only taken off it 4 months ago before the accident happened. Diagnosis, again, he had a traumatic brain injury. He had an extradural hemorrhage on the left side with extensive skull fracture this time, full thickness wound and cerebral contusions. We then did go on to CT and MR his spine, and he did have T1 to T7 spinal fractures. Theatre, again, he went for decompressive craniotomy and evacuation of his extradural hemorrhage. However, we believed this boy had fallen off a trampoline, but I think it was probably about 4 or 5 days later, maybe a week later, I think, this mum, the police had phoned us. We worked really close with the police in these cases to tell us that the mechanism of injury had recanted and that mum had reported that the child was found lying beneath the first floor window by the neighbour. So mum didn't actually know what had happened. Mum went to the police to report this, and they shared this information with the medical teams. Like I said, this wee boy had just been taken off the Child Protection Register 4 months previously to that, so this mum knew that if she told us the right story, she was in bother. Medical investigations, again, both initial and follow-up skeletal survey were normal, apart from his spinal fractures, which we already knew about. There was no new findings. Ophthalmology, so he didn't have bilateral, he had unilateral retinal hemorrhage. And again, his MR didn't show any new findings, it just showed us his extradural hemorrhage. And his bloods, cultures and virology were all completely unremarkable. This is his CT scan, so that's his initial scan right at the start, his post-op scan, and then his pre-discharge scan. And again, looking at that pre-discharge scan doesn't look as severe as the other one. However, you can see areas of infarction, again, on his left-hand side. So again, difficult to prognosticate, but could there be some sort of left-sided weakness later on in life? Discharge summary for him, this actually was really difficult. He was in probably for about 7 or 8 months, actually, and this all happened during COVID. So, like I say, COVID was really difficult for us all. He had mechanisms for intervention rather than interventions. So his pre-discharge case conference was held and the child was discharged into his mum's care, where they decided with ongoing social work support, ongoing input from hospital teams, GP, health visitors in relation to health. His name was placed back on the Child Protection Register under the main indicator of neglect. A referral was made to the Children's Reporter. Child Protection Case Conference was then to be held in 3 months. However, before the 3 months case conference was held, the patient was readmitted to ED. Mum again had told us he had an unwitnessed fall at home trying to climb in the stair gate. Another notification was completed by our teams, and again, due to his general presentation then, he was then kept in. He would be medically fit for discharge. However, because of his previous admission, he was then kept in and discharged into foster care the following day. So just quickly to summarise, there's both of these cases are similarities. Both sustained significant life-changing brain injuries. Both had retinal hemorrhage, one unilateral, one bilateral. They both had full child protection investigations carried out. Both had prolonged hospital admissions. Both ended up in foster care. Both primary caregivers didn't tell the real story of what had happened. Neither parent told us initially what the real story was. Differences, you've got a non-ambulant child for case 1, 5-month-old, as opposed to an ambulant child in case 2. In case 1, the mechanisms that we were told did not fit with the injury sustained. However, in case 2, the mechanisms were plausible when we actually found out what the real mechanism was. Case 1, loving family home, both parents employed and no previous concerns at all. Case 2, previous in the Child Protection Register and dad in prison. Social work intervened immediately with the first case. However, with our second case, they intervened after the second admission. And again, I think case 1 shows you, so the probability of abusive head trauma is high due to everything. However, there were no risk factors. Case 2, the probability of abusive head trauma was low. That was felt to be an accidental injury, and again was put in the register for neglect. His mum didn't push him out the window. You know, she didn't do it. However, there was other child protection issues around neglect and things like that, although he had many risk factors, and that's what we had to look at. Like Michael said, it's a totally MDT approach. There's a massive team that look after these kids. We're hopefully at the centre of it, and our role is to try and communicate, make these patients' journeys a lot easier. There's too many to mention, including third sector, education, police and social work. And again, just finally, what have we learned? Different IT communication systems, there's lots of technology gaps. You know, we deal with social work, we deal with police, we don't all share the same IT system, so it can make things difficult. Coordination difficulties, it can lead to duplication of work. And I think in these cases, role definition is really important. You know, we don't want to duplicate work and get loss of clarity. Benefit of the MTC role, there's always clear communications between all the different teams. Ability to prioritise information sharing, you know, it is important that you realise what you can and can't share. Ensure transparency. Communication is so important in these cases. Parents want to be kept up to date, and if you can keep them and keep a clear line of communication, you'll get far more back from them. And again, we've talked about decreased length of stay and things like that. And a bit of empowerment for patients and for families. Like I say, there's nothing worse if you genuinely know you haven't done anything and you're then having your baby taken off you. So again, if we can try and advocate for these patients, then that is the whole role. Any questions?
Can we do questions at the end, Lynsay, if that's okay? Thanks very much. That was excellent. So I think both Dr. Spears and Lynsay have really set the scene for us in terms of the scale of the challenge with non-accidental head injury, and also the complexities of conducting assessments and investigations, and you know what that can lead to, the kind of complex systems that we have to work in.